Imagine a patient sitting in a doctor's office. They're hopeful, they are scared, they want clarity. They receive a diagnosis and a treatment plan grounded in evidence-based medicine. But when they go home, many begin asking additional questions. What about food and water? What about sleep, environmental exposure, supplements, stress, exercise, off-patent medications, off-label use of medications, LED light therapy, food sensitivity testing, microbiome testing. What about this healthcare professional and that other one? They all have these long systems which, promise great, effects, even cures. So why don't they try some of those? For them, it's not about one intervention. It's a system of interventions. Whether we approve or not, millions of people are experimenting with multi-factor health regimens in the real world. The question is not whether they should. The question is, where does the data go? Now, where does the data go? It doesn't go anywhere right now. I want to tell you a story. I once met a Canadian veteran named Don. He had been told he had inoperable cancer. Alongside his medical care, he adopted a complex regimen, dietary changes, supplement and lifestyle shifts, and over time, he became to believe those decisions played a role in his survival. He lived decades behind his original prognosis. That was great. This is a story which is very powerful to me, but it's not evidence. It's not, it's actually anecdotal, and anecdotes do not prove causations. They do not establish mechanism. They should never replace controlled trials. But anecdotes do something important. They generate questions. And the policy question is this: when millions of people adopt complex, multi-variable regimens, where is that systematically studied? Modern medicine is one of humanity's greatest achievements. Randomized controlled trials have saved millions of lives. NIH's annual budget is approximately 45 to 50 billion per year. Of course, it supports extraordinary work in genetics, oncology, neuroscience, infectious disease, and pharmaceutical innovations. But our research architecture was optimized for something very specific: single molecules, isolated variables, standardized dosing, clear mechanistic pathways, and patented backed scalability. That model works beautifully for drug development. It works less smoothly for complex interacting systems. 6 in 10 American adults live with at least one chronic disease. 4 in 10 live with 2 or more. Chronic disease account for roughly 90% of US healthcare spending, and chronic disease is multi-factor. It involves diet, activity, sleep, stress, environment, metabolic health, behavior, and socioeconomic context. Yet, our dominant research tool remain largely reductionistic. We are very good at isolating variables. We are less equipped to model interacting systems over decades. Across the country, individuals independently adopting structured regimens involving food quality changes, processed food eliminations, exercise systems, sleep optimizations, supplement stacks, cosmetic ingredient avoidance, water filtrations, environmental toxin reduction, sometimes off-patent medications prescribed under supervision, not as isolated variables, but as systems. We have no national registry tracking these behaviors in relation to long-term outcomes. That is a measurement gap. NIH funding requires preclinical lab data, animal studies, clear biological rationale, carefully phased clinical designs. These safeguards protect patients, but they also favor interventions that are patentable, standardizable, commercially backed. If an intervention cannot be exclusively owned, there is little private sector incentive to fund large-scale trials. This is not corruption, it is incentive structure. And incentive structure shapes what becomes visible. Randomized trials answer, does X cause Y under controlled conditions? Longitudinal and observational systems answer, what patterns emerge when real people adopt complex health behavior over time? They do not prove causation, but they detect signals. Today we have computational tools that did not exist 20 years ago. Wearable data, for example, biomarker tracking, AI-driven multivariable modeling, and large-scale health registries. The technical barrier has fallen. The funding architecture has not fully caught up. This is not a call to dismantle pharmaceutical research. It is a call to balance it. I propose NIH dedicate a protected 25% allocation of its research funding specifically toward large-scale longitudinal multivariable registries. Also, observational cohorts tracking complex health regimens and comparative effectiveness research between low-cost and high-cost interventions. Finally, structured study of non-patentable multi-factor systems. 25%, not to replace RCTs, but to complement them, to build national infrastructure capable of measuring complexity responsibly. Specifically, we should establish a national chronic disease system registry. Let me say that again. A national chronic disease system registry. A voluntary program where individuals following structured health regimens under medical supervision can enroll. Standardized biomarker tracking could be included. Lifestyle variable logging, long-term outcome measurements could also be in the system. Not to validate everything, but to measure everything. Artificial intelligence is entering medicine rapidly. AI trains on published literature and structured data sets. If we understudy complex, non-commercial health systems, AI will inherit the same blind spots. The data sets we build today will shape diagnostic and treatment modeling tomorrow. This is not about current policy. It's about the architecture of future medicine. Philanthropy faces a quiet question. Do you want to fund the next patent-protected molecule? Or do you want to fund research into scalable, low-cost interventions involving food, water quality, environmental exposures, generic drugs, supplement patterns, behavioral system, and so on and so forth? These are not glamours. They're not blockbusters, but they are accessible. Accessibility matters in public health. Let me be clear. Some holistic regimens may fail. Some may show no benefits. Some may cause harm. This is precisely why they should be studied rigorously. The absence of data is not proof of effectiveness, but it's also not proof of ineffectiveness. A mature scientific culture measures before it dismisses. Medicine is evidence-based, but evidence only exists where we choose to look. Choosing what to study is choosing what becomes visible. And in public health, visibility determines funding, training, guidance, and access. The future of medicine may not depend solely on what we invent next. It may depend on whether we are willing to measure what people are already doing, not recklessly, not ideologically, but rigorously. That is not rebellion. This is a responsible inquiry. Thank you.